Well, welcome back. Our next presenter is Ms. Maysa Namakian, and she is the program manager for the Pacific Center for Special Care and the University of Pacific Arthur A. Dugan School of Dentistry. What is it, Dr.? Dugoni, I knew I'd say that wrong, School of Dentistry. Maysa aims to improve the oral health of underserved populations and has extensively researched the use and effectiveness of telehealth to increase access to dental health care. Please join me in welcoming Maysa. Thank you.
So I am a program manager at the University of Pacific School of Dentistry. It's out in San Francisco. And I'm going to be talking about this program we have started. It's called the Virtual Dental Home. It's a telehealth-enabled dental delivery system. And before I get into talking about the actual model and how it works, I kind of want to give you a little bit of a background as to what are the concepts that make up this model, why are we doing this, this new type of model, and just more the background. For those of you who are not familiar with the Institute of Medicine, it is a independent nonprofit organization that works outside of the government, and they provide a lot of advice to decision makers and the public on healthcare issues. And it's actually the health arm of the National Academy of Sciences, which was put together by Abraham Lincoln. And they typically answer a lot of questions about health and healthcare, and they put out 2 reports in 2011. One was called Advancing Oral Health in America, and the other was Improving Access to Oral Health Care to Vulnerable and Underserved Populations. And I should note that they put out 2 reports, which is a really big deal. The only other one was, if I remember correctly, the name of it was Quality Chasm, or I can't even remember the exact name of it, but there was one other report. So it was a big deal that oral health was represented in 2 different reports in 2011. And the green report, my director, Dr. Paul Glassman, actually had the pleasure of working on that report with a lot of other really smart people. So what was in this report? I'm going to kind of give you some highlights and actually break down into 2 of the recommendations. But some of the highlights is they really wanted that they were advising the public that we should really emphasize on disease prevention, oral health promotion, that the Department of Health and Human Services should invest in workforce innovations to improve oral health that focus on best use of new and existing oral health care providers. So looking at new workforce models, new professionals, and that CMS should explore new delivery and payment models for Medicare, Medicaid, and CHIP to improve access, quality, and coverage of oral health care across the lifespan. So again, also new dental delivery systems and new payment models. And everyone knows this part, but they had to reemphasize the fact that oral health should really be integrated into the overall health care system. And also create optimal laws. In spite of the existence of national accreditation standards on education and training of healthcare professionals, regulations defining supervision levels and scopes of practice vary widely from state to state and even by procedure. So I'm going to tell you in our model, we use someone called a registered dental hygienist in alternative practice, which is a specific type of provider in California with certain type of scope of practice. It only works there. So we have this division of the workforce where you can't necessarily take one professional and work across different state lines. So it gets a little confusing in all the different regulations. So in the second report, the access report, there was one specific recommendation, it was the second recommendation, that state legislatures should amend existing state laws, including practice acts, to maximize access to oral health care. So at a minimum, the state should look at expanding the allied dental professionals and really using them to the full extent of their education and training. They've been educated so much, so why not use them to their full extent? They should allow allied dental professionals to work in a variety of settings, not just in dental offices, but look at where else can dental professionals work and under what kind of supervision is appropriate. And lastly, allow for technology-supported remote collaboration and supervision. So This is the telehealth-enabled portion of it. The 8th recommendation was that Congress, the Department of Health and Human Services, federal agencies, and private foundations should fund oral health research and evaluation related to underserved and vulnerable populations, including new methods and technologies. So again, working in non-traditional settings, using non-dental professionals, new types of dental professionals, and telehealth. So the more research we do, the more evidence we'll gather and data to see what's the best model to use. And we should measure access, quality, and outcomes, and look at new payment and regulatory systems. So what are the general themes that came out of these 2 reports? The themes of chronic disease management, composition, licensing and deployment of the workforce, telehealth, quality measurement and improvement, and payment incentives. So in that last slide, I talked about chronic management. So right now, the dental delivery system is really focused on using acute care and surgical interventions, and we should really move to a system of chronic disease management. And what is the difference between these two? Most of you might know, but I'm just going to kind of go over this and show you the difference between the 2 different management styles. So in a surgical intervention, it's a provider-centric model, and it's typically care is provided in fixed offices and dental offices, dental clinics. Treatment is based on just a specific procedure, episodic-based care. Payment is also based on the procedure. And again, there's just a lot of emphasis on just the procedure that's being done. And let's look at this small little lesion, what do we do with it? And let's pay based on that little lesion, who did it. Whereas if we move to a chronic disease management model, it's more patient-centric. The care is delivered where people are to the extent that's possible. It's a management based on maintaining health across the life cycle of a condition, and also paying based on the value of health improvement across the life cycle of a condition. And lastly, emphasis is more placed on the risk assessment, prevention, and early intervention using biological, medical, behavioral, and social tools. So some of you may have heard the fact that we are moving into an era of accountability. This is a report that my director, Dr. Paul Glassman, produced. You can find this online. But what this means is that if we want to move to a model where we are really focusing on chronic disease management, we want to move, as it says here, is moving oral health care from volume to value. So currently, we are in a system that pays for services, like a specific procedure, or we pay for a certain number of encounters. We really want to move from that to value. Let's pay for if the person got healthier. Not, was that procedure done correctly, but let's pay someone if this patient got healthier in the end. That makes more sense. And how do we do that? Well, we have to first collect the appropriate data. And let's use meaningful use, so whether it's through electronic health records. And then let's make it accountable. So let's monitor, let's use this incentives based on these health outcomes. Let's pay if someone gets healthier. And then with those, let's put them into a new system. And a system where you are using the whole dental team and going into non-traditional settings. Let's look at new professionals. Let's use telehealth. Let's use chronic disease management. If you put all of this together, we can start looking at a system which is helping the patient get healthier over time, and not just this episodic-based encounters of, oh, the patient got this little lesion here and let's fix it. And with that, the cost of delivering dental care will also come down. So all of that, sorry, and it's really quick, but all of that is supposed to give you kind of a background into what's currently happening in the dental climate. And these are all the concepts that kind of make up the virtual dental home. So actually yesterday when I was flying over here, when I got on my flight from Denver to Des Moines, this gentleman who's sitting next to me Of course, it's the last minute here. I am playing on my phone until they tell you, like, turn it off, please put it away. And the gentleman said, "Is that an iPhone?" I was like, "Yeah." Is this the first time he's seen an iPhone? I was so surprised. I feel like everyone has an iPhone these days. And he's really surprised and was mesmerized by my iPhone. And I said, "Okay." Then I put it away, and then he starts to ask me, "So what do you do?" And normally when someone asks me what I do, it's already a tough enough question. I say I dental public health, and they have this blank stare of, I have no idea what that means. And then I try to tell them about virtual dental home, and they start to kind of get an idea. But this guy didn't even really know what an iPhone was, and how am I going to try to explain what telehealth-enabled dental delivery system is? It was a lost cause, so I didn't even really try. I said research, dental research. That was the best I could do. But so before I go into all the specifics of what is a virtual dental home, I think it's better that I show you this little video that we put together. And
dental disease has reached epidemic proportions in low-income children and vulnerable adults in California. It's getting worse. 24% of school children have never seen a dentist. Among Latino and African American children, over 50% have experienced dental decay, and almost 1/3 have untreated cavities. Untreated dental problems are also common in institutionalized elders, disabled adults, and other vulnerable populations. The Pacific Center for Special Care at the University of Pacific Arthur A. Dugoni School of Dentistry has developed a new model to address this problem. It's called the Virtual Dental Home.
The Virtual Dental Home is a new system of care. It's designed to move oral health services into community settings where vulnerable populations live and play and work and go to school and receive social services and general health services. In this system, we have dental hygienists and assistants who are able to be in those community settings, collect records, and post those to internet websites where dentists can actually access the records and establish a collaborative system of care between the dentists in their offices and these community professionals who are working in community settings. Once the dentist has reviewed the records, they'll be able to decide who can be kept healthy in the community and who needs to come into the dental office to have treatment completed. It'll actually be easier to get people into dental offices with this system because the dentist will already be familiar with what kind of work people need to have performed.
Good job. The beauty of this technology is that I'm able to take photographs and radiographs and any other dental findings on this child. It goes into a secure server, and then the dentist is able to access this information in the privacy of his own office without having to be on location.
This system is terrific because it allows me to evaluate Grace's records without having to be present. After Grace has been examined in the community, those records, x-rays, and photographs can be uploaded to the system. Then I can log on and review those x-rays and photographs from my office. These are Grace's x-rays that were taken while she was in the community. After evaluating these carefully, I noticed there are several areas of concern that are going to require her to come in for dental treatment.
And now, there are a number of things I can do for Grace to keep her mouth healthy in this community setting. I've just applied a fluoride varnish. I can also provide dental sealants and other preventive measures.
The Virtual Dental Home system is being launched across California in places like schools, nursing homes, community clinics, and group homes. This new system of care bridges the gap between community sites and dental offices and clinics. It will keep children, elders, disabled adults, and other low-income vulnerable populations healthy at a lower cost than other systems of care. This system will make a significant difference in the epidemic of dental disease across California.
And now, actually, you saw what this final diagram is going to look like, but I'm going to walk you through the different steps and how the virtual dental home really works. So we have allied dental personnel. In our case, we have employed both registered dental hygienists and alternative practice. Again, those are our the independent hygienists, the term for independent hygienists in California. We have registered dental hygienists working in public health settings, and we also have registered dental assistants. And what they do is they go on site to Head Start, to elementary schools, long-term care facilities, group homes for individuals with developmental disabilities, but they go on site and they're able to capture the initial set of records. So that includes, dental history, medical history.
Okay, here we go. So this is my little X-ray, all right? Open my, so it's gonna sit right in this chair, right down, all the way down, all the way down. You're doing a good job. Hold real still for me. Okay, open wide for me. Let's go wide.
It's
So,
small.
but since I can see in the proximal spaces here and there's really not any
Yeah.
cause for concern, that's part of, thank you.
Well, I'll skip to it, but they can take radiographs. So what I want you to actually notice about this photograph is how little amount of equipment they need. This happens to be at a school, but she has a portable dental unit, a laptop in the background, and a Nomad X-ray unit, which is pretty much the size of a hair dryer. It takes 1 or 2 trips from a car. They bring this all in and set up. Again, we have been doing this in all different types of settings. We don't always need a private room, but obviously works better with more space you have. But we're able to cram into any little small location if necessary. But I just want you to notice the simplicity of the setup of here. So they can take radiographs,
Yes.
photographs.
Good.
Great.
Yeah. Where you can see the sealant, you can
Right.
see it's a healthy tooth, but still, that's what we're dealing with in the
Exactly.
schools, yeah. Which that's a fair amount of calculus.
That's just a photograph of the tooth. And if you haven't seen it before, an intraoral camera is like the size of a little wand they're able to put into the mouth. And they can do restorative charting, periodontal charting. We do a camber risk assessment as well. And all of that information gets captured on the first visit and goes up into a cloud, into a secure server. So then the dentist is able to look at all of this. Looks like this. So again, the dentist will review it. And we do a store and forward, so we don't actually, it's not real time. And the reason for that is, patients aren't always available at an exact time, or the patient might not be the most cooperative, so you need to give a little bit extra time. And it just wouldn't really work out economically for the dentist to be sitting on the other end of their computer waiting for the images to pop up. So we found that it's more convenient for both the providers and the patients that it be a store and forward method where the dentist can review the records at any time that they like. But in our protocols, we have actually built in a time limit in which we want the dentist to review these records within a 24 to 48 hour window of the patient being seen. Because otherwise, records get forgotten about and the patient gets lost into the system. So we put a time limit that the dentists go online and access these records within 24 to 48 hours and review it. And when they're reviewing the records, there's really one basic decision that they're making. Is this patient healthy enough to go into a recall system and being seen in the community by the allied dental personnel? Or is this someone who has severe enough dental disease that they need to be referred to a dentist? And I should back up that about 2 years ago, we did a study on telehealth versus in-person decision-making. Because this is the basis of our project, we needed to figure out if you have a dentist see a patient in person, so if they do an exam in person, do they come up with the same results if they just review them on the computer? And we found out that yes, the dentist is able to make the same decision whether they see a patient in person or just review those same records on the computer. They were very consistent. If anything, there was more discrepancy between dentists even within the in-person visit. So If the dentist sees the records and they decide that this is a patient who's relatively healthy, again, they go into this recall system of being seen in the community by the dental hygienist. And then the dental hygienist can provide various forms of preventative procedures such as sealants, fluoride, cleanings, or even case management or just teaching or health education. These are some video. I think she's just placing a sealant.
Here we go. Open wide for me. This is a magic blue light. Let's check it. Good job. My best patient. Wow, that feels great.
I have to say, in that picture, I love that the patient is holding their own section. So they're able to provide these services on site. And there's actually a really interesting program in the state of California. So in all other states, if you want to change the scope of practice, or if you want to bring a new provider into the system, you go to the legislature and you're like, okay, I want hygienists to now start amputating arms. And like, well, how do you know it's safe? It's like, well, we're not allowed to test it out, so we don't know, but it sounds like a great idea. But in the state of California, there's something called the Health Workforce Pilot Project, which is administered by the Office of Statewide Health Planning and Development. And you submit this very extensive application, and if you're approved, you're able to test out these new duties under a safe environment. So what we have done, we've applied, we were approved, and now we're able to train our providers and collect data, and now whenever we want, we can go to the legislature and say, here's the data to do whatever we want. What we did is, that's our application, it's official. It's application 172. And in our application, we asked that registered dental assistant, hygienists, and RDHAPs are able to make the decision of what type of x-rays to take. And I know this sounds weird, but technically, these providers have a license to take x-rays, but they're not allowed to decide what type of x-ray to take. And if we did not get this waiver, it would automatically turn our initial visit into 2 appointments. You know, take photographs and then give it back to the dentist, and the dentist says, okay, now take bite wings and PAs. But this speeds up the process. The second duty that we included into this application is to place what is called an interim therapeutic restoration. And actually the pediatric people, I can't ever think of their names, they had a policy on this. And what it is, ITRs are these temporary restorations and the filling material is actually glass ionomer. As you can tell, I'm not a clinician, but I've been talking about this for a while, so I have some knowledge, but not all the knowledge. But what it is they place these temporary restorations on relatively shallow lesions. So if you go into a nursing home or a Head Start site and you see, this small little hole, well, why refer the child or the patient out to a dentist to get, drill out the tooth and put this restoration? You might as well, and the technique is actually really easy. There's no drilling involved and no anesthesia even needed. So they're able to just scoop out any decay with a spoon and put this temporary restoration on. It's very similar to like a sealant. And it's painless, easy, and so these 2 new duties we have trained our hygienists and assistants on, and so they're going out into the community, performing these duties. And I should note, though, the ITRs, they're only placed if the collaborating dentist says to do so. They don't treatment plan for it. The dentist still has to treatment plan for those temporary restorations. But if they say that it's okay and the patient's an acceptable patient, the tooth is an acceptable tooth, then they can go ahead and place it on the next visit. So again, this patient will go into the recall visit if they're considered healthy. If not, If the dentist reviews the records online and says, oh, look, they have some disease and it's really, you need to get them to a dental office, this is where we start the referral process and try to find dentists who can treat the patient. And the first step is hopefully to get the dentist to come on site. That would be the best solution, but it's not always possible. And if that's not possible, then we work with the dentist and try to get the patients out to the dental office or dental clinic. But we're really trying to, again, triage the patients and see who are the ones that need to be seen by a dentist or who are the ones that are healthy and to just keep in this recall system. But you should note that even after the referral process and they see the dentist, they do go back into this recall system because they hopefully got their lesions taken care of, and now the hygienist will see them in a couple months and go back to placing fluoride varnish and providing cleanings and hopefully stop any progression of disease right there in the community setting. So, there's different models of providing care, and we want to. This graph just shows you the cost of providing dental care at what stage. So the cheapest type of dental care is preventative care. And it's one where you provide on-site because you don't have any overhead as the dental office does. You're doing preventative procedures, and you're not neglecting any dental disease. So everyone is happy, they're healthy. The next type is bringing the dentist on site. So you have a little bit more overhead in terms of portable equipment, and if the dentist is involved, that means that you have some kind of restorative care that's needed. But again, you're still addressing the problems. The next is to a dental office. More equipment, more people. You're, again, probably delaying the care. And the last is if the patient needs to go to an emergency room or the hospital, which no one wants to go there. The patient must be in major pain. It's not the most comfortable environment. It's a very costly environment. We want to try to avoid that as much as possible. So our virtual dental home currently is being employed in 11 different sites, I think, right now. We keep expanding, so I keep forgetting the numbers, but right now we're in 11 different sites all throughout California, both in rural areas, even in San Francisco, LA, again, in Head Start, elementary schools, long-term care facilities, different types of settings. And just a couple months ago, we actually published a whole journal article in the California Dental Association Journal, and you can access this online. The whole journal was dedicated to our virtual dental home. And we had various different articles in there, I think about 6 articles, on just the whole concept of the model, how we're using telehealth to enable this system, that study that I talked about, looking at in-person versus telehealth-enabled exams, show that you get the same results. Just different preventative strategies and the policy implications of this model. I guess kind of got a little distributed, but basically what this whole system is, it's a collaborative, prevention-focused, geographically distributed, telehealth-enabled system of oral health care without walls. So again, trying to get out into the community, using all of our providers, using technology to bridge the providers to each other, but really trying to get to where the patients are. That's it. But I actually wanted to say one thing before I open up to questions, because the first question in the earlier presentation was about providing education to CNAs. And something that we have noticed in another project that we have done is it's really not all about just verbal education. We did a study in which we took a module that's called the Overcoming Obstacles. You know, it is the basic 1 hour module on oral health education, but we really sat down with the CNAs and showed them different tools with their patients. How can they provide better care? Like showed them different biting blocks and different types of just one-on-one, hands-on education. And we found that that worked a lot better than just giving a 1-hour presentation to them. Because like most, who wants to be spoken to? You know, it's more fun and more educational to go and do hands-on education with them. So that's just another, one little tip I would throw out there. I know it is difficult to teach some of the CNAs how to do the different daily oral health care, but they can, and I'm sure all of you can teach them. But now I want to open it up to any questions you might have, if there are any. Yes.
Thanks. I thought that was really a good presentation.
Oh, thank you.
I was going to ask you a couple of questions you may or may not know about the study where you said they looked at dentists looking at the telehealth information versus looking at them clinically. First of all, I wanted to know if the study sample that was used was just kids, or was it also elderly people who had prosthetic needs and whatever they have?
Yeah.
That's the first part. And the second part is, did they compare just the diagnoses, you know, caries and periodontal disease, or did they also compare the treatment plans that were generated based on those diagnoses?
Great. I can definitely answer those questions because I actually wrote that article, so I know a lot about it. So we actually conducted that study in a clinic at our university, and this clinic is called the Special Care Clinic, which actually deals more with patients with developmental disabilities, so more adults than kids. I don't think there were really any children involved in the study. And we had 3 dentists involved, and they all reviewed the x-rays and photographs of medical history, and really their only decision that they made is this someone that needs to go to a dental office and needs to be seen by a dentist for more restorative further care, or is this someone that could be seen by a hygienist for preventative care? So it was supposed to be used for our model. It wasn't really looking at treatment plans because, again, dentists have 20 different types of treatment plans, and there's no way of comparing those. But it was just the general idea of, you know, how extensive is their dental disease and what is the basic overall needs of that patient. Did I answer your question? Perfect.
Hi there.
Hi.
Paul has great skill at finding funding for various things, as
yes,
you well
he does.
know. There is a certain amount of hardware that's necessary to do these programs, and there is money needed to sustain it.
Sure.
How, apart from grants, on the more practical level, how is that going to be done, especially in the multiple sites that you have?
So that is correct. Right now we have different funding sources that are helping us do this model. I should note that actually our hygienists who are working in the long-term care facilities, they're able to bill for some of the procedures that they provide because they are independent hygienists. They're able to bill for some of those procedures. But, and then also some of our hygienists working in the schools, they are employees of an FQHC, so they aren't at this moment, but they can in the future bill for some of those encounters. It's a little tricky right now, and at this moment they feel more comfortable just relying on the grant funding, but they could eventually start billing for those encounters out in the community settings. But I would say yes, right now, you can't bill for many of these procedures. That's why we're trying to collect the data to show that this is a more effective, cost-effective, it's more patient-centered. We're trying to show them that it's more sustainable. It will be more effective and hopefully get legislation or get more policy changes to make this a fruitful model. But right now, yeah, there are a lot of challenges at this moment.
Hi. I've seen figures that said that after 90 days, many of these children that were referred for treatment still have not been accepted for treatment. Do you have any facts or figures on that in your model?
So, and I think, are you probably referring to the Head Start sites? Yeah. So for those of you not familiar, Head Start has a policy where they're supposed to do a screening and exam within the first 90 days. And, you know, first when we went in to the Head Starts, we thought this is fabulous. You know, they have dental on their minds. They're going to really work with us. Well, what we found is after 90 days, they didn't care about us anymore. They wanted us to go away. They got their sheet and form signed off, and they were happy with everything there was. So we learned really quickly that we had to change our model a little bit, and we really put a lot of emphasis in the beginning when we started signing contracts with the Head Starts that we're not just a 90-day provider. We want to create a dental home for these children, and if they have dental needs that can only be met by a dentist, we will work on referral. And so there has been a lot of emphasis on, you know, lots and lots of follow-up calls to the parents, to the, you know, different care providers for those children that need to see a dentist. So it's not 100% successful, but it's gotten a lot better. And you know, so in the beginning we were only working with hygienists, and now we've expanded the team to be both a hygienist and an assistant. So the assistant is taking on a lot of the duties of the case management and referral to the dentist. Again, they make a lot of phone calls, and then we get the Head Start staff also involved, and they have a really good relationship with the families, so they're able to leverage their relationship with the families to get the parents to comply with us and, you know, get those needs for the children. But again, that's why we also have the recall, so that at least they're getting some of the preventative procedures every, you know, how many months. And I should note that our recall system is based on whatever the dentist says to be. If they're a high-risk child or patient, we will see them every month if necessary. Or if they seem relatively healthy, we will see them every 4 or 6 months. It just depends whatever the dentist thinks is appropriate for the risk level of that child. Yes.
When you're talking about like the x-rays and that kind of thing, I guess in my mind right away, I was kind of thinking, well, I'm sure they have like a protocol.
Yeah.
I mean, because they do operate under protocols,
yes,
so that it's not totally independent decision making, right?
Oh, well, no, that's the waiver that we received. That we did create a curriculum as to, we help them decide how to, we help them, we educate them on how to decide.
In this situation, you do this.
Exactly,
okay.
exactly.
Well, that's
and actually,
what
I should note that originally we looked at the ADA guidelines on what's appropriate, and we did a little study, and we gave the protocols to both dentists and dental students, and we looked at they varied so much. We gave them case studies, and every patient that we gave them, they all came up with different answers. So the ADA guidelines weren't even that specific. So we tried to make it a little easier for them that, you know, if there's this much disease, you should probably be taking this many, and but yeah.
And my other question is, when you're going out places, what criteria do you use to pick your sites or to pick your schools? Do you do it on free and reduced lunch figures, or?
So, multiple answers to that. So sometimes it has to do with funding. Sometimes some of our funders say, you know, we really want you to work with Head Start sites in this county. So then we're limited to that population. I should say that for the
I have that problem too.
Yeah.
Funders kind of drive the program,
they
don't
do, but you know, I mean, we're working in all different types of underserved populations. For our long-term care facilities, we are in a rural area, and the hygienists happen to be working in that in those facilities, and we had a really good relationship with her, so we extended our virtual dental home to those facilities. So it depends on relationships, funding, where is the need. It varies.
Okay, thank you.
My question has to do with barriers,
yes,
with the legalities of the telehealth care and how you can overcome that. Clinical settings that rely on dental supervisions can be difficult to maintain schedules and et cetera.
Sure.
And then the other thing that goes back to that iPhone, when you have a majority of providers who maybe aren't even, they don't have an iPhone, how can you get them to do teledentistry? And where is the barriers overcoming those? How did you maybe achieve some of those?
That's actually very interesting. So we have been implementing our virtual dental home for the last 2 to 3 years. And in this 2 to 3 years, we've expanded quite a bit. And I do a lot of the training, or at least the telehealth portion of the training. And some of the providers that we had in the beginning, we inherited them. So they weren't the most tech savvy people, and so that was a huge barrier for me, and I had to spend a lot of time teaching them, this is an internet browser, click here, click there, so it was tough. Again, there's a lot of ongoing support. They have my cell phone, they constantly call me, how does this work, how does that work? Lots of training. And there's a lot of pros and cons to it, because even some of the hygienists that we work with in the beginning, they had never used electronic health records, some of them. There's pros and cons to that. One, if they've never used one before, well, then this is your introduction, and they see Namakian, which is the program that we use, and they love it. They think it's fabulous. And then people who have been using other electronic health records are like, well, my other electronic health record does this, and why doesn't yours do that? I'm like, well, everyone has different, all these programs are different. So yes, it is a barrier at times. Some of the newer providers that we are employing, we do try to look at their tech skills so that I don't have to be on the phone with them so often. We try to set that up as kind of a prerequisite, that at least they have some familiarity with computer. And besides that, they also have to be checking their email constantly. That was another huge issue. We actually have to put that in the contract. Please check your email every 24 hours at least, because what happens is that the hygienists, once they see the patients, they send an email to their dentist and says, I've seen patients A, B, C, and D, please go review the records online. If they're not looking at that, then they're not really participating in the project. They're not seeing any patients. So it was an issue to make sure that they're looking at their emails regularly. Was there another question in there?
Legalities.
Oh, yes, telehealth. Actually, I think it was about a year ago, and this is not my strong suit, but I think about a year ago in California, they did change some of the legislature that included, they changed it from telemedicine to telehealth. So it's more encompassing of all the various parts of the body. So, telehealth it's still a ways to come. Everything that is done on site is still under general supervision. So it is technically legal. And I know Dr. Helgeson can help me out here. He knows a lot more than I do on this subject matter.
I just thought I'd step up here and just make a couple more comments on that. One has to do with an exam, which is an existing ADA code, and whether or not the ADA code requires that the dentist do the exam in person or not. And we've actually had that reviewed by the ADA's council that reviews that issue. And if you read the language there, it's quite clear that the collection of the elements of the exam, blood pressure, medical history, x-rays, can be collected by members of the team subject to whatever their scope of practice and training is. And that the exam is the cognitive process of evaluating the information, forming a diagnosis or a set of diagnoses, and doing a treatment plan. And that is not required to be done in person. So that's the ADA's position on that. Now, does that mean that the Medicaid department is going to pay for that exam? Not necessarily, especially in Minnesota, where we have 10 different health plans, each with a different dental subcontractor and a different set of rules about under what circumstance will we pay for an exam. So we've had administrative systems coming down with different decisions about whether they'll pay for it. So that needs to be resolved. I think that's one of the outstanding issues, is we just need to have clarity between the ADA and all of the administrators on that issue. And this is a general issue for healthcare as a whole. You know, we think about when we go and we have some medical, a CT scan or, you know, different things. How many of them you had your radiologist even in the same building? Any show of hands? Those are done all over the country, and they're much more consequential than whether you have a cavity that needs an occlusal or an MO or something like that, you know. So the logic and the evidence around making this a covered service, I think, is pretty profound. There are issues with those handheld x-rays, the nomads. I'm not sure what the rules are in Iowa. We've spent 3 years in Minnesota working with our department that regulates the use of those on whether we can actually hold them by hand or not. And I forget how many states allow you to do that, but we've got a special variance and we have to use dosimeters and all this other junk, you know, which I think is crazy because the studies have been done. But there are issues regarding some of the specific technologies and whether you can use those, you know, in your state. So you have to kind of be aware of that. And I just want to make the comment too that in the staff model, one of the advantages of having a big staff model is you have people whose job is community care coordinator and who sit at a desk and are there all day long and can call people when they're home and take calls at all different times and actually can be there for the families and so on. And then we have trained dental liaisons who's a staff member at every single contracted site that we train, and they know our systems so that we don't have people falling through the cracks. We have, you know, the availability of on-site care without discrimination on the basis of source of payment or anything like that. So we can provide most of the care right on site without having to do a lot of care coordination, but we have the staff set up to actually do that, and they have the time, and that's what they're good at. It's really hard to get hygienists or assistants, people whose real job is to do clinical stuff, to be available for all these calls and the callbacks and stuff and the emails, because they're coming at all different wacky times. And so to be able to get on the phone with somebody, you know, live, if you're a clinician, is really hard. So anyway, thank you.
Yeah, thank you. Is that it?
Well, I get to be the last question, and but I want to go back to, you talked about that the nursing home is in a rural area. So tell us a little bit about what you know about the experience that they're having with the telehealth, and what we're finding in some of these rural communities in Iowa is that the nursing home is starting to become the hub. The hub for care, right. For all care. And so, you know, is there any kind of, you know, certainly anecdotal information that you can provide to us on what's going on in the rural areas?
Sure. So, again, our hygienist, we've been working with her for a very long time on various different projects, and she's working at several long-term care facilities in the city called Visalia in California, which is relatively rural, and there are not that many dentists to go out to her facility, so she's just all by herself checking out to these facilities. The dentists don't want to go at all, and she's made a lot of changes at these sites. You know, I'm not going to say it's the perfect site, but she's had to spend a lot of time talking to administrators and really trying to get them engaged into oral health, and as a result, engaging the staff and educating them, and so that they can provide the proper type of daily mouth care for the patients. Unfortunately, I do have to say, as a sad note though, we did have one big dental company come and push her out of the facility, a mobile company there that doesn't provide the best care. So, but the good thing is we know that because they have a track record of not doing so well, that they're gonna be out and she'll be back in soon enough because the patients love her. You know, she's able to go in and see them. I've gone a few times to do some site visits with her. You know, these patients have these I didn't even know because I'm not, again, a clinician, but the trach cubes, and they're in the bed, they can barely move, and she's able to go provide, some of the best care to these patients right at the bedside, and they love her. And again, I really wanted to emphasize that point about the education, because what I do remember vividly is the CNAs saying that they had a hard time brushing the teeth, and there was actually one patient that they would never go into his room because he smelled so bad. And, they weren't brushing his teeth, and finally the hygienist came in, and, she did her tricks and was able to get the patient to open their mouth, and they found that he was bleeding inside, and that's why it smelled so bad, and no one knew why. So, she came in several times and cleaned his mouth and finally helped him, and then the CNAs were able to come into his room again, and it smelled fine, and they were able to provide the care for him that he needed. But yeah, it's a battle, but it's getting better. Yeah. Well, thank you very much.